Ready? Okay. Thanks, Carol. What Carol means is she's ahead. Words with Friends is a Scrabble type game, and she is ahead, but there's always a kid. It's not over. So the event today will be in two parts. I'm going to give a background on some of the science on low carbohydrate diets to treat diabetes, and Carol will then describe the story in a real context, namely with her daughter Sadie. So along those lines, I want to tell you an old joke first. In the old days in Russia, not every town could afford a rabbi. So there would be traveling rabbis who went on a horse-drawn cart with a chauffeur from town to town. And at one point, a traveling rabbi says, you know, I'm so tired of doing this. I've been to so many towns. I tell this sermon, and I'm really beat. And his chauffeur says, well, you know, Rabbi, I've heard you give this sermon. They don't know us in this town. We'll change clothes, and you can take a rest, sit in the back of the synagogue, and I'll give the sermon. So they get to the next town, and the chauffeur, would-be rabbi, gives the sermon, and at the end, somebody in the congregation asks him a question, and he says, well, that's a very good question. It's actually an elementary question in theology, and so elementary, I'm going to ask my chauffeur in the back of the synagogue to answer that for you. I'm the lead author with several of the major researchers in low carbohydrate diets for the treatment of diabetes. We published this a couple of years ago. We saw it as a kind of manifesto of sorry, 1 second here. We saw it as a kind of manifesto for use of low carbohydrate diets for diabetes. Now, diabetes, you know, is a disease of carbohydrate intolerance. People with type 1 are making insufficient insulin or no insulin so that they can't process dietary carbohydrate. People with type 2 do have insulin, but generally their peripheral cells cannot handle the insulin, and there is also, with time, deteriorating function in the pancreas, which is the organ that makes insulin. So on the face of it, you would assume that the burden of proof rests with anybody who would suggest anything but dietary carbohydrate. That's not how it's played out. And this paper was not, I wouldn't say it was not rebutted, certainly. In fact, it was largely ignored, indicating the general resistance of the medical establishment to low-carb diets. This year, however, there have been two really landmark studies, one on type 2 diabetes with hundreds of subjects, and one on type 2, which took the idea that, while it's widely voiced, is rarely implemented, to go and ask the patients, and you can actually talk to the patients on social media, and they tracked down what people were doing with low-carb diets, and of course, they all had medical advice, so the physicians could be contacted. The problem with low-carb diets is still that they are counter to the standing wisdom of health agencies. And the problem is that I'm going to make a case, and you have to ask the question, why should you listen to it when all the experts are at least mildly opposed to it? To answer this, I'll tell you what I tell medical students when I teach them. The first question we ask medical students is, do you think there's ever been a time in the history of medicine when the great majority of physicians and scientists held to a bad idea, one that was dangerous, and they stuck with it even in the face of contradictory evidence. Do you think there's ever been such a time? Well, of course they do. Everybody can think of at least one. And I suggest that if you think it's happened before, you at least have to consider the possibility that this is another such period. Before I get into it, I'm going to see what you know. So this is a questionnaire that we give to incoming medical students. They have not been through the curriculum yet. They haven't even had the first biochemistry course. And so you can think about the answers. I won't ask you to vote. So the most energy-dense nutrient, that is the most calories per gram, what is that? Well, I think most people know that it's fat. Fat has 9, the kilocalorie, written kcal, is the dietary calorie. It's the physical kilocalorie. And fat has 9 kilocalories per gram, carbohydrate has only 4. We tell students they have to learn it, and we threaten them with the national boards. Surprisingly, to me this is surprising that anybody got this wrong, because it's an elementary point in nutrition. And the explanation, of course, is that they're all young and healthy and thin, and they don't bother paying much attention to nutrition. We hope to change that while they're in the school. So the next question we ask is, for a slice of buttered bread, which is more fattening? The bread, the butter, both equal, or you can't tell. And the graphic is here so you know what buttered bread is. Well, of course you can't tell. Now we explain to students that in the medical school we don't knowingly ask trick questions. But this is intended as a trick question because you can't tell. And it's important because of the concept of relative properties. So energy density per gram, it's referred to in physical science as a intensive property. It's like temperature, and 2 slices of bread have the same calories per gram as 1 slice of bread. So you have to know how many grams. And this will show up in things like when you read the media and they tell you that a particular treatment improves risk by 30%, you have to be suspicious, because you need to know what did you start with, how many people were there, and what did you get. Of course, the students, this was a trick question. They guessed, you got to figure out the total grams by converting this intensive property, relative property, to an absolute property. So during the epidemic of obesity and diabetes, which is how we describe the last 40 years, the macronutrient that increased most was carbohydrate, fat, or protein, or all about the same. Well, it turns out to be carbohydrate. The students did not know this. And almost all of the increase in calories in the past 40 years has been due to carbohydrate. So what you're looking at here along the vertical axis is the years during which the NHANES is the National Health and Nutrition Examination Survey, something like that. And they collect data on those dates. But these are absolute energy intake, and you can see that energy intake is due to all of the total change is due to the carbohydrate. The saturated fat, which you're continually warned against, is actually numerically going down. I don't think this data is sufficiently accurate to say it's really 14%, but it certainly hasn't gone up. And this is from the USDA and shows you that almost everything went up during the obesity epidemic. We're not going to get real benefit by just adding fruits and vegetables. They went up too. The only thing that went down were eggs, and interestingly, in the shaded portion, red meat. So the problem is, you are what you eat is not a good idea. Fat doesn't make you fat, at least if there's no carbohydrate there. Saturated fat does not clog your arteries, and it's better to say you are what your body does with what you eat. In other words, metabolism describes how foods are processed. The controlling factor are hormones, and those affect the rates of metabolic processes. So this is evidence that telling you how this low-fat idea, which we're fighting against, got started. This is from 1984, and you don't have to read this, but basically it was claiming that we got cardiovascular disease all worked out because we lowered cholesterol and there was a benefit for the patients. And therefore you should stop eating stuff with a lot of fat and a lot of cholesterol. Not everybody was convinced. In particular, Dr. Edward Ahrens, who was an expert at Rockefeller, said this was a drug study. Nobody ate anything, and the drug cholestyramine prevented reabsorption of cholesterol and had what you would guess might be a certain degree of gastric distress. But in any case, it wasn't a diet study. And things have changed, and there are a lot of critics, and Reader's Digest had this covered. The problem is, it's been very hard to, it's hard to get rid of the low-fat idea because we have a number of large, expensive studies. They're considered failures, but really they're actually successes because they ask, is a low-fat diet beneficial for cardiovascular disease? They're frequently well done, and they successfully show that no, a low-fat diet is not good for protecting against heart disease. They are sometimes considered as failures because the investigators thought that they were asking the question, can I prove my point of view? And they could not. But these are good studies, and this in particular is considered the mother of all random controlled trials, meaning people assigned at random, and over 8 years they reduced total fat, increased vegetables, fruits, grains, and so on. There was no benefit for risk of cardiovascular disease, and in separate reports from that study there was no benefit to diabetes or obesity or just about anything else. Everybody, the head of the NIH got on social media immediately to say that nothing had changed, and so everybody had a different take. This is my own take on it. If you don't know, Bethesda is where the NIH is located. So this is the two critical questions that we ask students, and that is, what about the dietary requirement for carbohydrate? 130 grams, 50%, no requirement. Similarly, what is recommended by the USD, the American Diabetes Association, NIH, what are their recommendations? So you might think about this for a second. There is no dietary requirement for carbohydrate. And you know this because you don't store very much. Your liver stores a ballpark of 200 grams tops, I think. And that's good for a couple of days of energy. The concern is primarily for the brain, and that would be gone in 2 days, which means that if there were really a dietary requirement for carbohydrate, if you got stranded in the Andes for 2 weeks, you would die. But that doesn't happen. The carbohydrate intake recommended by the health agencies is a little hard to pin down. Sometimes they say they don't have a recommendation, but in any case, it's usually in the ballpark of 50% of calories. And that we think is too much. Our students are pretty much divided. as little as possible should be what they recommend. That is, if you have diabetes. People without diabetes can tolerate carbohydrates in varying degrees, but there is no requirement as such. So this is the big player. And insulin, I don't want to go through the details of it, but insulin, glucose is the primary stimulus for insulin, and it controls fat. Most of all, it stops the liver from producing glucose, and that's generally believed to be the major cause of high blood glucose in both types of diabetes. That is, the liver becomes insensitive to insulin, and if you now have dietary glucose coming in on top, of course you're going to have high blood glucose. Some of the textbooks say it's generally thought that in diabetes you have a failure of uptake to clear the glucose, and that's part of it, but I think it's generally believed that's not the main part of the picture. So this is what happens when you take a high carbohydrate meal. Glucose goes up and insulin goes up. Glucagon generally opposes insulin, but I just want you to look at, this is what a normal response to dietary glucose is. There's a spike in the blood glucose, and then as the insulin appears, it's cleared, and it's, in a normal person, it's being used and, if necessary, replenished by the liver. But insulin-dependent diabetes mellitus is the old name for type 1, and you can see that the insulin spike goes up quite a bit higher and comes down very slowly. And the glucagon, which opposes this, is inhibited by glucose and insulin. Let me say first that people point out that there are 100 hormones, and emphasizing insulin may be exaggerating things, and that's true. I'll give you my analogy for metabolism. I think that metabolism is like American football. There are at least 22 different things going on at once, and it may be hard to see what the play is, but the TV will follow the quarterback because that's your best bet. And that for any single play, that may not be the key to the play. It may be downfield blocking or the size of the defensive line, but most of the time you get far with the quarterback. Insulin is the quarterback of metabolism, and so it's where we look first. So what is a low carbohydrate diet? A low carbohydrate diet is less than 130 grams a day. That's what the American Diabetes Association specifies. This comes from a misunderstanding about what the brain requires. Under conditions where there is adequate glucose, the brain will use 130 grams. But if there's no food coming in, or if you're on a low-carb diet, if there's no carbohydrate coming in, the brain will use, and use preferentially, an alternative fuel. Now, the brain doesn't use fat, but the breakdown of fat to fatty acids allows you to generate small compounds called ketone bodies. Acetoacetate and beta-hydroxybutyrate are the names of the two compounds that can supply energy for the brain in the absence of glucose. And after a few days without food, or a few days on a low-carb diet, the brain prefers ketone bodies to glucose. If you've been without food for a few days, the requirement of the brain for glucose is down to about 65 grams a day. So the pioneer in understanding human ketogenic metabolism was a researcher named George Cahill, and he told my colleague that when he found out that they misunderstood his work, it was too late, and this number has kicked around. Now, the ketogenic diet, whether or not ketosis actually occurs is considered to be, it varies from person to person, but it's considered to be less than about 50 grams. It should not be confused with capital ketogenic diet, which is a long-standing specific diet to treat epilepsy. And it's one of the things that makes us very interested in ketogenic diets, because it can have dramatic life-saving effects. Half of the people with epilepsy half of them have great improvement with a ketogenic diet, and astoundingly, 20% of them are cured. So when you go to these conferences, the patient is frequently there and may have a slide of themselves with bruises from banging into things during clonic seizures, and those have all disappeared since they were on a ketogenic diet. Again, there's no requirement. So this is our recommendation, and I think it's important. This is a very important quotation. You can opt out of surgery and you can not take your meds, but you cannot not be on a diet. So it's important to find out what the best diet is, because you're going to be on a diet even if you take medication. This is another good quotation. So these are I'm going to give you 3 or 4 points of evidence, and then talk a little, tell you very briefly about the recent study in type 1. Obviously, high blood glucose, hyperglycemia, is the feature of diabetes, and dietary carbohydrate is the most effective way to reduce it. This is from a researcher named Dashti, and you can see that the blue, which is the very low carbohydrate ketogenic diet, again less than 50 grams or so, does much better than an explicitly low-cal diet. This is the hemoglobin A1C, and one of the problems with high glucose is that glucose is chemically reactive and will react with different proteins. In particular with hemoglobin, the material called hemoglobin A1C is considered a reflection of persistent high blood glucose. There is a warning in that if you have diabetes and you're taking medication, you have to reduce the medication in advance of the diet to avoid hypoglycemia. That is, you don't want low blood glucose. An alternative interpretation, it shows you how effective the diet is because it does the same thing as the drug. This is from the most recent study, and it shows you the green are those patients whose hemoglobin A1C got better, and there are more points in the low carbohydrate arm. There are more people in the low carbohydrate arm, but you can see that the drift is almost in opposite directions from usual care. The health agencies recommend losing weight on your diet to help diabetes. What this is showing you here is fluctuations in blood glucose across a day. The red is before I believe it's 10 weeks of a low-carb trial, and it shows you what happens after that time in patients who have been constrained not to gain or lose weight. So there's no change in body mass here, and you can see that the fluctuations in blood glucose have gone way down, and this is breakfast, lunch, dinner, and the snacks. And you can see again the hemoglobin A1C is much better in the low carb, in the after rather than before. And again, insulin tracks the difference in glucose, but it's not as simple to explain. So you don't need to lose weight, and that's a real advantage for a low carb diet for a person with diabetes, because in the end it's not that easy to lose weight. Nonetheless, low-carb diets, nothing is better for weight loss, and this is an interesting case. This is a study comparing low-carbohydrate diets with so-called healthy eating, and what you see is that half of the people on the low-carb diet lost more weight than anybody in the healthy eating. Recently, this paper came out by the same author, Pamela Dyson, and it says low-carb diets for type 2 diabetes, what's the latest evidence? And her conclusion was overall low-carbohydrate diets failed to show superiority over higher carbohydrate, which is kind of surprising since her own data shows the opposite. But she didn't cite her own data. She did not cite her previous work. And we give her credit for modesty. Most of us try to cite our work as much as we can. And I couldn't figure this out until I realized the bell went off. Her paper is about the latest evidence. She didn't look at any of the old evidence that might. This indicates the degree of bias in this field, and I don't know who said this, but that was my reaction. So there are many studies trying to show, as I mentioned, that total and saturated fat increase the risk of cardiovascular disease, and this has been impossible to show. And I'll just summarize what's been done with low-carb diets to describe two studies. The study from Jenkins compared a low glycemic index diet. Now, the glycemic index is the measure of carbohydrate that specifically raises blood glucose. So it's a good idea. When I was in school, we were taught that sugar raised your blood glucose, but starch did not. And Jenkins, among other people, said, wait a minute, is that really true? And it turns out not to be true. It depends on different foods and different combinations. Potatoes will raise your blood glucose much more than ice cream. And that's the GI diet. It's a great idea, but in practice it's not very effective because it's very hard to calculate. It's not convenient if you're an actual dieter. Eric Westman at Duke compared a low GI diet with a real low-carb diet. And this is just the kind of master slide for low-carb diets. Because it's good to compare them to a low GI diet, which has somewhat the same point of view. You want to control blood glucose. They're better for weight loss. They're better for glycemic control. How could they not be? And they're better for HDL. This is the so-called good cholesterol. High-density lipoprotein cholesterol is the particle that carries cholesterol in the blood, and it's considered beneficial to have high HDL. LDL, which is the major assumed risk by most doctors, doesn't change much. And triglycerides, which are fat in the blood, is tremendously different on a low-carb diet. It's virtually definition of a low-carb diet. My own fell in half when I started a low-carb diet. And this is the important point that patients with type 2 diabetes reduce their medication, or they can actually eliminate it. So this is a study from Duke, and of all but 2 of the people in the study were on drugs, and all but 2 of those reduced their drugs, and 7 of them came off medication entirely. And I don't know a disease that isn't considered to be improved if you come off medication. Now, of course, in type 1, patients have to take insulin because they're not making their own insulin. Before I tell you that, this is a very important quotation from Eric Westman, and he said that he could taper patients off as much as 150 units of insulin, which is a very high amount of insulin in a little more than a week. And my reaction to this was, if I were a physician, I would immediately call Eric Westman and say, is this characteristic? Is this guy an outlier? It's not. Other people report similar things. Now, type 1 diabetes does require insulin, but the effects are not the same as endogenous insulin. So this is your pancreas, the variations in your pancreas over time trying to control blood glucose, and you can see it keeps a very steady level. A person with type 1 diabetes who is dependent on external insulin cannot do as well. The problem is you have to match your insulin to your intake, and the lower the carbohydrate, the easier it is to do that. This is a figure from R.G. Dykman. He's a physicist, and he obviously is good at making figures, and his son has type 1 diabetes, and this is what the response on a high-carb meal plan is. And quite remarkably, this is what happens on a low-carb meal plan. I was at a conference and showed this to the representative from AstraZeneca, a drug company with diabetes, and they were totally impressed. Getting to the top of AstraZeneca and getting them to be interested, that's not easy to do. But I don't know that they wouldn't be. So the best thing, if you're going to match, if you're going to match insulin to carbohydrate intake, it should be a small one. So this is the recent management of type 1 diabetes paper. I'm going to just show you the two highlights to me. This is considered in the range of normal hemoglobin A1C. And the conclusion that they make, and I know the authors, they don't usually go off the deep end, this is exceptional glycemic control. So I think this is the case that we have a way of dealing with diabetes. In case of type 2, we have a virtual cure, and in type 1, we have the best way of dealing with it. Now I'm going to turn this over to Carol.